Hello everyone, my name is Dr. Susan Kafle, and continuing on the previous video, in this video we'll be discussing about the lateral and medial medullary syndromes. This is a series of the topic localizing the strokes, part 2. So let's begin. In this video we'll be learning about the lateral medullary or Wallenbach syndrome and the medial medullary or the Deserine syndrome. This is a picture of the brainstem. As I told in the previous video, the brainstem can be divided by this line into the right and left halves, and by the horizontal lines we can divide it into three parts, that is the midbrain, pons, and the medulla. Now each half, that is the right and left half, they also can be divided into the medial and the lateral sides. So the topmost one is the midbrain, and there is a rule of force that I should tell you because that is relevant, and it becomes easy to know the syndromes if we know that. So we divide the cranial nerves into three groups, that is the first four cranial nerves, and then cranial nerve 5, 6, 7, and 8, and then lastly cranial nerves 9, 10, 11, and 12. Now the first four cranial nerves, they should originate above the pons, so that means from the midbrain, but 1 and 2 they already originate above the midbrain. So in midbrain we have only cranial nerves 3 and 4. In pons we have cranial nerves 5, 6, 7, and 8, and in the medulla we should actually have 9, 10, 11, and 12, but the 11th cranial nerve nuclei, it lies in the lower, in the cervical spinal cord. So this is an exception to the rule. Medulla has 9, 10, 12, and midbrain does not have the first and the second cranial nerves, otherwise the rule is followed. Now there is also another rule, so that rule is the rule of 12s. All the cranial nerves that are prime numbers of the number 12, they lie towards the center. So what are the prime numbers of 12? 1, 2, 3, 4, 6, and 12. But cranial nerves 1 and 2, they are originating above the midbrain, so we have plotted just cranial number 3, 4, 6, and 12. All right. Now since we have already written the cranial nerves 3 and 4 towards the medial side in the midbrain, there are no cranial nerve nuclei on the lateral side. In the pons we have written 6 on the medial side. So wait a minute, we have written 6 on the medial side, so on the lateral side we have 5, 7, and 8, but I have written a long 5 that extends into the medulla because the spinal trigeminal nucleus, the fibers, they pass through the pons and then they have the nuclei in the medulla. So 5 extends down into the medulla, 7 is here on the lateral pons, and cranial nerve number 8, it has two parts, the cochlear and the vestibular part. Cochlear part nuclei lies wholly on the pons, whereas the vestibular nuclei, it extends into the medulla as well, just like I showed with the spinal trigeminal nucleus. In the medulla now, since we have already plotted cranial nerve number 12 on the medial side, the nuclei of cranial nerve number 9 and 10 lie on the lateral side. Apart from this, we should also know that there are two cerebellar peduncles. The middle cerebellar peduncle, or MCP, it lies completely in the area of the pons, whereas the inferior cerebellar peduncle, it lies in both the pons and the medulla. So this also becomes relevant when we are discussing the syndromes. And after this we have the tracts. In the tracts, towards the medial side we have one ascending tract and the other is the descending tract. The ascending tract that is in the medial side is the dorsal column medial lemniscal pathway, which carries the sensations of fine touch, proprioception, vibration, and position sense from the spinal cord. And the other is the corticospinal tract, which descends downward from the cerebral cortex into the spinal cord. These two tracts, this dorsal column medial lemniscal pathway, how it comes upwards. So if this is a brain and this is a part of midbrain and this is the spinal cord, the dorsal column, it ascends upward and just caudal to the medulla, it decussets and goes to the other side and ascends upwards. All right, so this is about the dorsal column medial lemniscal pathway. Now, what about the corticospinal tract? The corticospinal tract, this is the midbrain, this is the spinal cord, it descends downward on the same side. At the caudal medulla, it crosses and it goes towards the opposite side. So in the medial part of the medulla and even in the pons, I've just drawn it below here because it would cause the crowding of the image and things would get difficult. Now talking about the lateral part of the brainstem, we have again one descending tract. So that tract is the sympathetic fibers that are originating from the hypothalamus. So and the other is the ascending tract, that is the spinothalamic tract. So sympathetic fibers, as I said, they originate from the hypothalamus on the same side and then go down to the spinal cord and then again ascend upwards and supply different areas of the face. So lesions of this would cause the ipsilateral Horner syndrome. Now what about this spinothalamic tract? Talking about the spinothalamic tract, it carries the sensation of pain and temperature. What it does is, this is midbrain and this is the spinal cord. So it originates here in the spinal cord, crosses immediately and then ascends upward. So this is crossing in the spinal cord itself, whereas our dorsal column, it crossed just distal to the brainstem, that is in the caudal medulla. This you have to remember. All right, now if we know these many things, then we are good to go with the different types of syndromes. Now let's talk about the lateral medullary syndrome. It is also called the Wallenberg syndrome. So as I discussed in the previous video, the lateral medullary syndrome is due to involvement of the posterior inferior cerebellar artery. So let's discuss the lateral medullary syndrome. We divided the brain into 3 different regions, and each half we divided into lateral and medial part. In the medulla we have cranial nerves 9, 10 and 12. It also gets the cranial nerves nuclei from the pons, that is cranial nerve 5 and vestibular part of cranial nerve number 8, and then it has cranial nerves 9 and 10, and then the inferior cerebellar peduncle is also there. And we have 2 tracts, the ascending tract, that is the spinothalamic tract, and the sympathetic fibers. Now when we are talking about any syndromes, we should always talk about them in relation to 3 things. Remember C, T and P. C means the cranial nerve nuclei, T means the tracts, and P means the peduncles, especially with the pontine and the medullary syndromes. So as we can see, there is involvement of this cranial nerve number 5 nuclei, so that is the spinal trigeminal nucleus. Because of this, there will be ipsilateral loss of pain and temperature on the face. There is involvement of vestibular part of cranial nerve number 8, and because of this there will be vertigo, nystagmus, nausea, vomiting, ataxia and impaired vestibulo-ocular reflex. These things will always remain the same, so you need to know the signs of a particular cranial nerve nuclei involvement. So now after that we have the involvement of cranial nerve nuclei number 9, because of which there is loss of taste from the posterior 1/3 of the tongue and there is impaired gag reflex. So gag reflex, the afferent fibers are carried by cranial nerve number 9, whereas efferent fibers are carried by cranial nerve number 10. So even in cranial nerve nuclei 10 lesion, we have impaired gag reflex, and apart from this we have dysphagia, hoarseness and uvular deviation to the opposite side. Now we talk about the tracts. There are 2 tracts. One is the descending tract. This is the sympathetic fiber, and because of its involvement there is ipsilateral Horner syndrome, the signs of which are ptosis, anhidrosis and meiosis. And an ascending tract, that is the spinothalamic tract, is also involved, so there is contralateral loss of pain and temperature from the body. As I told in the previous slide, the spinothalamic tract, it originates in the spinal cord and is crossing, it crosses directly in the spinal cord and ascends upwards. So we are having the lesion over here, so this would cause the loss of pain and temperature over here. All right, so coming back to our mnemonic CTP, we talked about the cranial nerve nuclei, the tracts, now the peduncles. So inferior cerebellar peduncle is lying here, so we have its involvement in lateral medullary syndrome, so that leads to ipsilateral ataxia and dysmetria. So this is all about the lateral medullary syndrome. Now I want to tell you guys about a rule, that is the rule of 17, which helps you remember the deviations in different cranial nerves involvement. So it applies in the lower motor neuron lesions of cranial nerves. So we add the numbers to make them 17. 12 plus 5 is 17 and 10 plus 7 is equal to 17. So in cranial nerves 12 and 5, if there is involvement of lower motor neuron, then there will be deviation to the same side. So how to remember this? So you remember 12. So 12 is the hypoglossal nerve, and you remember the mnemonic your wound, sorry. So towards the side of your wound you protrude your tongue out, right? So the deviation, this helps you remember that the deviation is occurring towards that side. And even in cranial nerve number 5, the deviation will occur on the same side of the lesion. Whereas in the lower motor neuron lesions of cranial nerve 10 and 7, the deviation will be towards the opposite side. For example, in facial nerve palsy, if there is lesion on this side, the face will deviate to the opposite side. Now let's talk about the medial medullary syndrome, which is also called the Deserine syndrome. In medial medullary syndrome, we have the involvement of this artery, so that is the anterior spinal artery. So in the medullary syndrome, we have involvement of cranial nerve nuclei number 12, because it is the prime numbers of 12, they are lying on the medial side, as I said before. And then we have involvement of two tracts, one ascending and one descending. This one is the dorsal column medial lemniscal pathway, and the other one is the corticospinal tract. So in the medial medullary syndrome or Deserine syndrome, we have the involvement of, again let's remember CTP. So here I started with the tracts directly. There are no peduncles, so there are cranial nerve nuclei and the tracts only. So the descending tract is the corticospinal tract, and because of its involvement, there will be hemiparesis on the contralateral side. All right. Then we have the ascending tract. This tract is the dorsal column medial lemniscal pathway. So because of its involvement, there is contralateral loss of fine touch, proprioception, vibration, and position sense. And there is involvement of a cranial nerve nuclei number 12. So there will be ipsilateral hypoglossal nerve palsy. So as I told before, the rule of 17, 12 plus 5 is equal to 17. In 12 cranial nerve, there will be deviation of the tongue towards the same side. That's it for this video, guys. I hope you enjoyed watching it, and I hope that this will help in your exam. Thank you. I'll be back in the next video with the medial and lateral pontine syndromes. See you then. Have a nice day.